Welcome to the deep dive. Today we are jumping right into, well, probably the fastest, highest stakes few seconds in medicine.
Yeah, we're talking about securing an emergency airway.
Right, rapid sequence intubation, RSI. You know, when a patient's crashing, everything needs to happen perfectly. Speed, precision.
Absolutely. Confidence is key.
But there's this one specific moment, this detail, that's actually become kind of a fierce debate among critical care folks.
It sounds simple, doesn't it? Just the order you push the drugs in.
Exactly. The sedative and the paralytic.
Yeah.
Which one goes first?
And look, this isn't just, academic navel-gazing. We're talking about drugs that work at slightly different speeds.
And that difference? It could mean everything for a really sick patient.
Especially when their oxygen levels are dropping fast. So we're diving into this whole rocketamine versus keturonium thing.
Rocketamine being rocuronium first, the paralytic, then ketamine, the sedative.
And keturonium, the sort of traditional way. Ketamine first, then rocuronium.
Our mission today is to really unpack this. We've got some clinical data on timing.
And we need to weigh that against the, frankly, quite scary risk of anesthetic awareness. Being awake but paralyzed.
It's a tough balance. Is the risk of hypoxia worse than the risk of that kind of psychological trauma?
That's the core question.
So we looked at a key study on the drug order timing and also a couple of really good expert analyses digging into the drug kinetics and, importantly, those ethical risks.
Okay, let's get into it.
First off, RSI is everywhere, right? It's not some niche procedure.
Oh, definitely not. I mean, the numbers are huge. Over 85% of ED intubations.
Yeah, and a massive chunk in the ICU, too, something like 75%.
And the basic goal is pretty clear. You use the paralytic, the NMBA.
Neuromuscular blocking agent.
Right. Use that to relax everything, the vocal cords, the jaw. It just makes getting the breathing tube in much easier and safer.
It gets you that perfect view, stops the patient potentially fighting the tube, avoids complications. Makes sense.
But as it's basic. And here's the rub. You can't just paralyze someone, obviously.
No, they have to be completely unconscious first. That's non-negotiable.
So we use strong sedatives like ketamine or etomidate. But the problem is, as soon as that sedative really hits...
They stop breathing, or at least breathe much less effectively. Hypoventilation, apnea.
Yeah, exactly. So you're inducing apnea, a dangerous state, to achieve unconsciousness before paralysis.
Which is why the traditional way, keturonium sedative first, makes intuitive sense. Protect the mind first.
Right. But then this observational study came along. It looked at critically ill patients getting both drugs, the sedative and the paralytic, within like 30 seconds of each other.
And what did they find? This is the bit that really stirred things up, wasn't it?
It was. The study suggested that giving the NMBA before the sedative...
So the paralytic first.
Yeah, rocketamine.
Yeah.
Was linked to about a 6-second reduction in apnea time.
6 seconds shorter from pushing drugs to the laryngoscope coming out.
That's what they reported. Now, 6 seconds, and it sounds small maybe.
But in critical care, 6 seconds can feel like an eternity.
It absolutely can. But we have to pump the brakes on that finding straight away.
Why is that?
Well, the sources we looked at point out a huge issue with that study. Selection bias. Like, really significant.
Okay.
A massive 73% of the patients in that study already received the NMBA first.
Wait, 73%. So 3/4 of them were already doing the rocketamine technique.
Yep.
So are we really comparing two distinct approaches fairly? Or just kind of observing what the majority were already doing?
That's the question. It makes it hard to say that this sequence is definitively better based just on this study. It might just reflect existing practice patterns in those specific hospitals.
Crucially, did they track awareness?
No, that's the other massive limitation. They measured the time, but not the potential downside, the risk of the patient being aware. That whole side of the equation is missing from this data.
Okay, so let's put those 6 seconds in context. Why might they matter so much? We're not talking about a healthy person getting their appendix out.
Not at all. Think about your really high-risk patient, maybe someone morbidly obese, already in severe respiratory failure. Maybe their O2 sat is only 96%, even with maximum oxygen support.
Right, they have basically no reserve.
Exactly. For them, every single second they're not breathing, their oxygen level is plummeting.
So we need to define a couple of key time intervals for you, the listener.
First is the safe apnea time. How long can the patient actually tolerate not breathing before their oxygen drops to critically low levels?
For a healthy person, maybe quite a while.
Yeah, 8-10 minutes sometimes. But for that critically ill patient we just described, it could be closer to 2 minutes, maybe even less.
2 minutes. Wow, That's incredibly short when you think about everything that needs to happen.
It is. And that leads to the second critical time, the sedation lag time.
Okay, what's that?
This is that really dangerous period after the sedative has made the patient unconscious and apneic, but before the paralytic has fully kicked in.
Ah, so they're not breathing, but they're not paralyzed yet either.
Exactly. And during that lag, bad things are happening physiologically. Their own breathing effort is gone. The lungs can start to collapse or de-recruit. O2 falls, CO2 rises.
So the goal of a perfectly smooth RSI is to make that lag time as short as humanly possible, ideally 0.
Precisely. Minimize that window of vulnerability.
Okay, let's look at the drugs themselves then, the kinetics. We're talking high doses for RSI, right?
Yeah, big doses, like 1.2 to 1.4 milligrams per kilogram for rocuronium, the paralytic, and 1.5 to 2 for ketamine, the sedative.
And ketamine's the fast one here.
Relatively, yeah. Onset is usually around 30 to 40 seconds. And with that big RSI dose, you pretty much expect a period of, well, complete apnea and unconsciousness very quickly.
And rocuronium.
Rock is the slow poke. Full paralysis. You're looking at maybe 50 to 90 seconds after you push it.
90 seconds. That's a long time in this scenario.
It can be. And remember, if the patient's in shock, if their circulation is sluggish, it could take even longer for the drug to reach the muscles.
Okay, so let's model the traditional way first.
Yeah.
Keturonium, ketamine first, then rock.
Right. So you push the ketamine. 30 seconds later, boom, patient's unconscious, apneic. But you push the rocuronium right after it, maybe a second or two later. It's still making its way. Full paralysis might not happen until, say, 65 seconds. Maybe even 105 seconds after the initial drug push.
Whoa. So with keturonium, you're creating this potentially really long sedation lag time.
Yeah, it could be around a minute long. A whole minute where the patient is out, not breathing, but not paralyzed.
And that minute just ate up half of their 2-minute safe apnea time we talked about.
Exactly, before you even put the laryngoscope in. Plus, there's another risk.
What's that?
If the doctor assumes, okay, they stopped breathing, they must be paralyzed, and they try to intubate too early.
Ah, gag reflex, vomiting.
Yeah, big risk of vomiting and aspiration if they aren't fully relaxed yet.
Okay, now let's flip it. Rocketamine. Rocuronium first, then ketamine immediately after.
So here you're pushing the slower drug, rock, first, then the faster one, ketamine.
How did that change the timing?
Well, the ketamine still acts fast. It'll probably still cause unconsciousness around, let's say, 45 seconds after its push, which is maybe 46 seconds into the whole sequence.
Okay.
But because you push the rocuronium first, its clock has already been ticking for those 45 seconds. So its effect, the paralysis, is much more likely to happen right around the same time or just slightly after the ketamine makes them unconscious.
Ah, I see. You're essentially giving this slower drug a head start so that their effects overlap much sooner.
Exactly. The idea is that rocketamine leads to a much shorter sedation lag time. You significantly reduce that dangerous window where they're apneic but not paralyzed.
And that presumably is where that potential 6-second advantage comes from. Less time wasted in that lag phase.
That's the theoretical benefit, yes. Which brings us to the elephant in the room.
If it saves time, potentially critical time, why isn't everyone doing rocketamine?
Because the risk. The huge counter-argument.
Yeah.
Anesthetic awareness.
Being awake, paralyzed, unable to move, unable to scream while someone is putting a tube down your throat.
It's a terrifying prospect.
And there was an attempt to quantify this risk, right? A simulation.
Yes. One of the sources discussed a Monte Carlo simulation. They basically ran computer models for 5,000 simulated patients, comparing the onset times of the drugs.
What did it show for the rocketamine sequence?
The results were, they were pretty sobering. The simulation predicted that when rocuronium was given first, 25.3% of the simulated patients would experience some duration of awareness.
1 in 4.
1 in 4. And for 15.4%, that awareness lasted longer than 5 seconds.
Okay, that's a really high number. But you mentioned limitations.
Yeah, a crucial one. The simulation was based on data from healthy surgical patients.
Not critically ill patients in the ED or ICU.
Right, and critical illness can definitely change how drugs are metabolized, how quickly they work, so we can't directly extrapolate these exact percentages to our RSI population. But still.
But the potential for a significant risk is clearly there. It's not theoretical.
And it becomes even less theoretical when you hear actual patient accounts.
Like the Rick Laurent case mentioned in the source.
Exactly. He received rocuronium first and described experiencing total psychic terror for at least 60 seconds. He knew he was paralyzed, fully aware, couldn't move, couldn't communicate. The trauma is profound.
Hearing that puts the 6-second time saving in a very different light.
It absolutely does. You're weighing this potential, maybe small physiological time gain against a simulated 1 in 4 risk of conscious paralysis and the resulting potentially lifelong psychological trauma.
That is just an awful trade-off to have to consider.
It really highlights the ethical tightrope clinicians walk.
So if the drug order itself is such a difficult choice, maybe we should focus on other things we can control to make RSI safer overall, buying more time.
Absolutely. The drug order is just one piece of a very complex puzzle. There are other strategies.
Like what?
Well, think about pre-treatment. Sometimes we give meds like midazolam beforehand for anxiety and amnesia.
Right.
But one source made a good point. In really severe respiratory failure, maybe you don't want to suppress their respiratory drive or anxiety too much before induction. That little bit of anxious hyperventilation might actually be helping them oxygenate better right before you take their breathing away.
Interesting. So maybe skip the midazolam in those cases. What else?
The absolute basics remain paramount. Excellent pre-oxygenation. Get those oxygen reserves as high as possible before you start.
Fill the tank.
Fill the tank. And then maintain oxygen delivery during the apnea period, apneic oxygenation, usually with a nasal cannula.
Standard stuff. But what about really tough cases? The ones with almost no safe apnea time?
That's where techniques like non-invasive ventilation, like BiPAP, used during the sedation and paralysis phase come in, sometimes called VAPOX.
Ventilator-assisted pre-oxygenation.
Kind of, yeah. You basically keep the BiPAP mask on with a backup breathing rate even as the drugs are going in.
Who does that do?
It provides positive pressure, it helps keep the lungs open, prevents that collapse, that de-recruitment we talked about when they become apneic. It essentially fights against the loss of lung volume and buys you more time.
So better pre-ox, apneic oxygenation, maybe even VAPOX. These things can extend the safe apnea time regardless of drug order.
Exactly. Optimize everything else around the procedure. And we also need to remember, awareness isn't just about the specific drug order debate.
Right. It can happen for other reasons.
For sure. Probably the most common cause is inadequate sedation after the tube is in.
Because the rocuronium lasts a long time.
Much longer than ketamine or etomidate usually. So if you don't start a continuous sedation drip or give more boluses quickly, the patient could wake up while still paralyzed from the rock. That's a huge risk area.
And maybe inadequate dosing up front.
Yeah, especially in patients with tolerance, maybe due to substance abuse history or chronic opioid use. They might need higher doses of sedative to ensure they stay unconscious.
Okay, so let's bring it back. Rocketamine versus keturonium. Given everything we've discussed, the shaky 6-second data, the very real awareness risk, what's the clinical bottom line? Should people change their practice?
Based on the sources, the consensus seems pretty nuanced. It's definitely not a one-size-fits-all answer.
Okay.
For most patients, probably the vast majority undergoing RSI who aren't right on the brink of coding, the traditional keturonium approach, sedative first, is likely still the safest default.
Prioritize preventing awareness over a questionable time advantage.
Exactly. But there might be that rare extreme exception. The patient with an incredibly short, safe apnea time where you genuinely believe those few seconds might be the difference between life and anoxic brain death.
The true crash intubation.
Right. In that absolute life or death moment, maybe, just maybe, the immediate physiological risk of death from hypoxia outweighs the psychological risk of awareness.
Right.
And in that specific rare context, rocketamine might be justifiable.
Calculated risk in extremis.
A very calculated risk. But for routine practice, the evidence just isn't there to support switching and accepting that awareness risk.
So the overall recommendation from the experts seems to be,
Until we have better evidence, like a solid, randomized, controlled trial that confirms the time saving and carefully measures awareness, clinicians should probably stick with the RSI method they are most comfortable and proficient with.
familiarity and smooth execution are critical too.
Absolutely. Confidence in performing the sequence you know well under pressure is incredibly important for success. Fumbling with an unfamiliar sequence is probably more dangerous.
It really does boil down to this deep ethical tension, doesn't it?
It does. How do you weigh that immediate measurable risk hypoxia against a risk that's psychological, often hidden, but potentially devastating awareness?
Especially when the patient who experiences awareness might not remember it clearly or might not feel able to talk about it, but carries that trauma.
Right. It makes you think, doesn't it? If you do choose a path, like rocketamine in that extreme case, what's the responsibility afterwards?
To maybe prepare the patient, Or debrief them carefully. Check in about their experience.
Exactly, because saving life is paramount, of course, but the quality of that life, the psychological impact of our interventions, that matters profoundly too. It's a really sobering thought about the true costs, sometimes hidden, of buying those critical seconds.